Assalamu alaikum wa rahmatullahi wa barakatuh. Bismillah ar-Rahman ar-Rahim. My name is Dr. Mujtaba Quadri, and I'm delighted to join this prestigious GK NEPCON 2025 of the Gunasta Shaya Kendra People's Health Center, Dhaka, Bangladesh Annual Conference 2025 as an invited speaker from Islamabad, Pakistan. My background includes primary schooling at St. Placid's High School in Chittagong. So I'm here back home as I would like to think with my brothers and sisters in Bangladesh. So, without further ado, I apologize for not being able to be here in person because of some personal emergencies. But let's move on from here and let's start off with the presentation. So, today's job would be to for us to appreciate the global epidemiology and burden of glomerular disease and review the structural, functional, immunological correlates necessary for an understanding in glomerulonephritidis, explore diverse examples with clinical case presentations of GN, and try to emphasize a probabilistic approach to differential diagnosis of glomerular disease, approach diagnostic reasoning by employing tests or imaging with high likelihood ratios, stress acquisition of skills to critically appraise and apply literature results to inform GN practice, and highlight a partnership model to provide evidence-informed integrated care for glomerular disease. So if you just look at this particular 30-year distribution of the global burden of glomerulonephritis, you can see that there's a big peak in early age groups in terms of both prevalence and incidence, with another second peak in the middle age groups. However, the morbidity mortality increases at the upper extremes over the age of 60 to 80, in that range, as well as the disability associated life years lost. The glomerulus is very familiar to all of you, but we know that we have an afferent arteriole and efferent arteriole, which gives off this capillary network out here. And you have this tubular basement membrane epithelium, which basically continues as the parietal layer of the Bowman's capsule and turns around as a visceral layer, and in the process, it's from its basement membrane, it gives off these epithelial foot processes into the subepithelial space. However, the capillary network contributes to the endothelial layer of the Bowman's of the glomerular basement membrane, and this is put into place and held snugly together by the connective tissue, the interstitium, where a lot of the actions in terms of cytokines and inflammatory mediators takes place or recruits. So we need to be aware that with the normal size of the kidney, 10 to 13 centimeters, there are radiological correlates in terms of the echogenicity when there's scarring from grades 1 to 4. And we obviously have, the filtration function of the kidney is basically to generate an ultrafiltrate of plasma, and all the factors which affect the arteriolar tone, afferent or efferent, basically determine whether somebody can be controlled in terms of proteinuria or continues to have unabated proteinuria in terms of whether we are using vasodilators or efferent arteriolar vasodilators. So these are some of the ways we can manipulate the proteinuria, at least from a hemodynamic point of view. We do have creatinine and cystatin C, the new kid on the block, as a marker of renal function. And however, the newer CKD, EP, and the KDIGO equations supersede the previous MDRD and Cockcroft-Gault formulae and have excluded even race from the equation. We just look at one case of this young man who had gross hematuria after running a marathon, and all his parameters were normal except he had 4+ blood and traced urine. Protein and urine sediment revealed some dysmorphic RBCs, but no CAS. And his workup was essentially normal with 200 milligrams per gram protein creatinine ratio. But since he was anxious, what would be the course? Well, one would be thinking in terms of reassurance initially, because this is a classical nutcracker exercise-induced hematuria, and with a normal blood pressure, serum creatinine, and absence of proteinuria or red blood cell CAS. But the presence of dysmorphic RBCs is certainly supportive. So with a low pretest probability, no further tests need to be ordered at this point in time. So normally we have obviously 150 milligrams of protein in 24 hours, which can be up to 300 milligrams during pregnancy, and 24-hour urine collection for protein to creatinine or albumin to creatinine ratio or protein to creatinine ratio from an aliquot of the 24-hour urine is also equally good. So besides these spot samples, urine dipstick is still very useful. And for dipstick negative proteinuria, one needs to consider urine protein electrophoresis. However, we should be aware that the serum albumin can be measured by bromocresol green method, which will give a higher baseline normal as opposed to bromocresol purple, which has a lower baseline normal. Transiently, with fever, inflammatory states, albumin infusion, you can get proteinuria, you can get orthostatic proteinuria, in those who are basically ambulatory most of the time, and the timed supine sample obviously falls within the normal limits for that particular time period. You can have overflow proteinuria with light chains, and you have glomerular proteinuria is usually typically over 1 gram, whereas tubular interstitial is usually typically less than 1 gram. You can also have post-obstructive proteinuria with obstructive uropathy and also bladder tumors. Normally, with glomerular disease, when you are looking at hematuria, you can either go towards the urological side or you can go with the nephrological side when there's an associated proteinuria of more than 500 milligrams with dysmorphic RBCs or RBC CAS. And then this requires serological, hematological evaluation, which may include blood cultures, anti-GBM, ANCA, complement levels, cryoglobulins, Hep B, C, serologies, VDRL, HIV, ASLO, anticeptolizin O titers, malaria, thick and thin smears, or COVID antigen, and eventually renal biopsy. However, one should think of UTI and do a urine culture to rule out UTI when there's associated pyuria, or consider hemoglobin electrophoresis or urine cytology in the right setting, along with imaging, including a renal ultrasound and CTKUB, followed by periodic urine analysis, and sometimes you may end up with a urogenital biopsy. The urine dipstick, very useful. As you can see, most of us use it to look at for varying degrees of blood or RBCs in the urine, as well as to think of nitrites and UTIs, but also for the protein, where the different grades of 1 plus, 2 plus, 3 plus, 4 plus can be equivalent to about 300 milligrams of proteinuria for 1 plus, about 1 gram for 2 plus, about 3 grams in 24 hours for 3 plus, and about 10 grams in 24 hours for 4 plus as a guesstimate. Let's go to case number 2, where this is a 20-year-old male who presents with rusty brown cola-colored urine with a decrease in urine output in the past 2 days. He has fever of 39 degrees earlier on, sore throat with painful submandibular lymph nodes around 2 weeks back. He had a blood pressure of 150 by 100 on examination with minimal pedal edema. Creatinine is doubled to 2 milligrams per deciliter. He has 3 plus blood and 2 plus protein on dipstick. Urine albumin to creatinine ratio is 500 milligrams per gram. Urine sediment reveals dysmorphic RBCs, 10 to 12 RBC CAS. ASO titer is elevated at 1:400. CM33 is low at 10 and C4 is normal. And he's placed on salt restriction and loop diuretics and asked when he should come back to clinic. So in general, this appears to be post-infectious classical GN based on group beta hemolytic group A strep and a history of cola-colored urine 2 weeks after throat infection, which can be 4 weeks after skin infection, a high blood pressure, urine dipstick with blood, mild proteinuria, active sediment with RBC CAS and serology positivity, along with a low C3 based on alternate complement pathway activation, suggests a nephritic syndrome, and plan is for an expectant management for this mostly self-limited disease, but which requires close follow-up. And if the C3 remains low beyond 3 months, we have to think of mesangiocapillary GNs and C3GN related GNs here. The urine sediment, of course, you can, there are various methods of doing it, but in general, one would spin in a centrifuge the suspended urine sample with a balance across it at 3,000 revolutions per minute for 5 minutes. And then, after decanting the top, you resuspend the pellet in the remaining sample and then pipette it out, put it on a cover, on a slide where a cover slip has already been placed, and you place it at the edge, and with capillarity all that the sediment goes under that slide, and you look at the carefully at the four corners at under 40 power or 160 power, and you may be lucky to see red cell casts embedded here within this cast-like structure with no nuclei that are visible. But on phase contrast microscopy, you can see crenated RBCs, and that is part of the and the acanthocytes, which can be also equally good in terms of their specificity. Case 3 is a 60-year-old female who was diagnosed with diabetes about 7 years back. Blood pressure is 140/90. Fundoscopy reveals diabetic retinopathy, and she has peripheral neuropathy. Her urine albumin to creatinine ratio is 500 milligrams per gram. Creatinine is 0.8. EGFR is 72. HbA1c is suboptimal at 8.2. On metformin, linagliptin, and valsartan. She agrees to increase her valsartan dose and to optimize DM control. As a professor of public health, she has heard about the EMPA and DAPA-CKD RCT results and seeks to expert advice about benefits in Asians. And here I would say that, of course, this disease appears to be type 2 DM-related diabetic kidney disease with a lag time delay in diagnosis. With the associated diabetic retinopathy and neuropathy. She has suboptimal blood pressure control, needs to have a standardized office measurement of at least 120/80 or less, and hemoglobin A1c close to 7%. As far as SGLT2 inhibitors are concerned, the number needed to treat in the DAPA-CKD study for the primary outcome was 19, and subgroup analysis in Asians wasn't very supportive of benefit, at least in renal terms, for Asians. So that's why a shared decision is necessary. In general, when you do have diabetic kidney disease, I think it's important to have an idea about the various stages, stage 1 to stage 5, at the time of presentation, along with A1 to A3 in terms of the proteinuria range. And as you can see that, the classical diabetic kidney disease may be delayed in stage 1 for several years with good interventions that we'll talk about. And you can also have regression of albuminuria with tight sugar control and ACE inhibition. But you can have rapid decliners, and those who are non-proteinuric and non-albuminuric may actually have a very rapid decline of renal function. This was a subgroup analysis from the New England Journal of Medicine DAPA-CKD study, and this forest plot shows the hazard ratios on the left of the midline, which shows benefit compared with placebo. But if you look at Asia, in Asia, the Asian geographic region, the benefit was 0.7, but the confidence intervals hit the point of no effect, 1.00 or 1.00, which means that this effect in terms of primary outcome benefits of decline of rate of renal function and end-stage renal disease was not statistically significant. And also the same thing you can see there's not very good results with a very wide confidence intervals in Asian population, in the Asian race elsewhere as well. So we do not yet know whether DAPA from a renal point of view is beneficial in Asians based on the way we looked at this study. So normally I would suggest an evidence-based approach. How do we look at pretest probability of a particular diagnosis? Well, the prevalence is important. The clinical expertise and the clinical prediction rules based on history and physical diagnosis will determine the pretest probability. The history and physical examinations have their own sensitivity and specificity. And in terms of whether further testing needs to be done, one needs to have a probabilistic approach, which I will talk about soon. Secondary glomerular diseases are generally more common than primary. For example, diabetic kidney disease and lupus currently, and type 2 diabetes is certainly very common, up to about 5-10 million global population, type 1, 27 million. And you can imagine that with 30 to 40% of those having nephropathy, that it is a very major cause of chronic glomerulonephritis that needs to be addressed. And we also understand that in terms of prevalence, if a child comes to you, 90% with proteinuria, it's minimal change disease. So this is what this particular cartoon is showing. And we need to be aware of the burden that this is not just kidney failure, but associated heart failure and cardiovascular death that we have to look at in terms of the metabolic syndrome, and a combined management of diabetes, heart, and kidney is required from an early stage. So this Fagan's nomogram, it shows you a pretest probability of a particular diagnosis on this bar, a post-test probability on this bar, likelihood ratios are here. And if you can think of a positive likelihood ratio as sensitivity over 1 minus specificity, and a negative likelihood ratio as 1 minus sensitivity over specificity, and a test with likelihood ratio more than 10 usually will increase your post-test probability significantly. For instance, here, if you started off at a probability of 0.02, you went up with this test with a likelihood ratio of 18.75 to probability of 0.28, about a 14-fold increase. And likewise for a negative likelihood ratio, and it can decrease the post-test probability. And so in general, for tests, I would suggest that if your disease probability, pre-test probability is more than 70%, we order 1 or 2 confirmatory tests, no more. If it is less than 30%, the pre-test probability, do not waste money on esoteric tests. But if it's between the diagnostic uncertainty of 30 to 70%, use tests with good likelihood ratios to increase your post-test probability. So the anti-PLA2R antibody in general has a very high specificity, but the sensitivity is also not too bad in most series. So that means it has a high likelihood ratio. However, in diabetics, you can also have false positives, and that one needs to be aware of. But in general, if one does the immunofluorescence methodology, that would be more specific. And if one does the Western blot, which is only available experimentally in experimental labs, then it can be much more certainty can be added to your diagnostic acumen. So normally clinical manifestations, well, we all understand we can present with hematuria, proteinuria, renal function impairment, acute kidney injuries, less often, but can occur with minimal change or primary FSGS, or of course with rapidly progressive glomerulonephritis. You can have hypertension, edema, hypercoagulability, or somebody can present with pulmonary embolism, for instance. But you can also have systemic features. For instance, constitutionally, we could have fevers, chills, weight loss, night sweats, fatigue, and deep-seated abscesses, for instance, staph, or when bacterial endocarditis. Likewise, epistaxis, sinusitis would be very highly suggestive of some of those giant cell polyangiitis, oral ulcers of lupus. Similarly, cardiovascular murmurs in endocarditis, or in lupus, and you can also have pericarditis with lupus. Lungs, you can have the pulmonary renal syndromes with simultaneous hemoptysis or infiltrates or nodules, either with anti-GBM disease or with ANCA-related vasculitides. Abdomen, again, enteritis, colitis, pancreatitis can occur with microscopic polyarthritis. Seizures can occur with TTP, peripheral neuropathy with periarthritis or microscopic polyarthritis, like we said. Likewise, the same as in digital ischemia infarction with microscopic polyarthritis. Purpura or rash you can have with both IG vasculitis and lupus. And of course, arthritis, arthralgias, myalgias, non-specific rheumatological diseases, and various infections can present with positive blood cultures and fever and deep-seated abscesses. So this is a typical malar rash, which spares the nasal bridge in a lupus patient. And this is the typical IgA vasculitis rash occurring in the extensor surfaces that is common, as well as on the buttocks. So in general, lab tests and imaging have their own positive and negative likelihood ratios, which help in ruling in or ruling out disease. For example, prenated RBCs have 52% sensitivity, 98% specificity, which gives a positive likelihood ratio of 26 for thinking of proliferative glomerulonephritis. Tests with high positive likelihood ratios help rule in diagnosis, or very low negative likelihood ratios rule out diagnosis. And we've already mentioned, if the pretest probability is low, don't waste more money. And when the pretest probability is high, also don't waste too much money, just a few confirmatory tests. And it's the intermediate zone that you are required to do these specific tests. So tests cost money, especially in our parts of the world. When you're looking at imaging and ultrasound of the kidneys, help define acuity of the disease with a normal size 10 to 12, but with chronic GN, it could be 8 centimeters or less, with increased echogenicity grades 3, 4 that we can subsequently look at in this particular slide. So the urine dipstick is a good screening test. We already mentioned the 24-hour urine collection for proteinuria would require urine creatinine simultaneously excreted of around 15 to 25 milligrams per kilograms in males and 10 to 20 milligrams per kilograms in females. The spot urine albumin to creatinine ratio is practical, pragmatic, and clinically useful. And the urine sediment is a KDIGO recommended integral part of the diagnostic workup now, and we need to be aware of the importance of acanthocytes, created RBC, the RBC casts, as well as oval fat bodies and fatty casts and nephrotics. So these panels from going from 1, 2, 3, 4, progressively the kidney echogenicity from normal goes up to a grade from grade 1 goes up to grade 2, grade 3, and grade 4, depending on how it looks in relation to the corticomedullary differentiation being lost progressively and how it looks compared to the liver echogenicity, starting with less than liver, then to equal to the liver, and more than the liver. The chemistry, of course, you need all the electrolytes and BUN creatinine, cystatin C in some cases, if you want, hemoglobin A1C, albumin, lipid profile, and to determine whether you're dealing with an RPGN versus nephrotic and nephritic syndromes. And hematologically, you need the CBC, helpful in of course, HUSTTP and also post-infectious GN. And then for peripheral smear is mandatory, especially when you're suspecting HUSTTP states. And for malaria states, you need the thin smears. You should routinely do blood cultures and urine cultures when you have suspicion of post-infectious IgA dominant staph GN or various forms of shunt nephritis. So in general, for serological tests, one should uncover the immunopathogenetic mechanism of disease. They should be used contextually. For example, in RPGN, you would normally order ANA, ANCA, anti-GBM. In membranous, you can order ANA for secondary lupus-related membranous, but PLA2R antibody, NEL1, which is very common in our parts of the world now, second only to PLA2R, due to mercurials in bleaching, facial bleaches and hair bleaches, thrombospondin 7SA, not too often commercially available, but may be associated with malignancies. And of course, Hep B, C serologies may be important. For the monoclonal immunodeposition disease, immunofixation, and serum protein electrophoresis, serum-free kappa lambda light chains would be very specific. And for lupus, of course, C3, C4, ANA, anti-double-stranded DNA, but also if it's lupus membranous, EXT1, EXT2 may be associated. And similarly, when you have granulomatous polyangiitis, the proteinase 3, formerly C-ANCA, and for microscopic polyarthritis, myeloperoxidase or the P-ANCA formulae would be very useful. And cryoglobulins and rheumatoid factor can be positive in hepatitis C, GN, and DNA, JB9, and fibrillary GN if it is available to you. The role of T-cell immunity with its helper T-cells and interleukins, role of B-cell immunity with immunoglobulins IgG, 1, 2, 3, 4, IgM, galactose-deficient IgA, we all understand are important in pathogenesis, particularly in membranous as well as in IgA nephropathy. But in addition to that, the activation of the MBL pathway or the classical and alternate complement pathways, one needs to be aware of that as they are very important in differentiating between things like mesangiocapillary GN or post-infectious GN with alternate pathway activation versus lupus with both classical and alternate pathway activation. The role of anti-nephrin antibodies is being described in minimal change disease. APOL1A gene variant has been well characterized in FSGS, particularly collapsing varieties. PLA2R antibody, NEL1 thrombospondin, we already mentioned in membranous. SUPAR is now touted as one factor in FSGS, which can be commercially available soon. And of course, your P-ANCA and C-ANCA, along with the anti-IgG, IgM role of the anti-GBM disease, and the roles of neutrophils, macrophages, and the neutrophil extracellular traps and cytokines in various forms of granulomatous angiitides. So in general, if you look at whether it's infection or whether it's autoimmune, the final common pathway will be hematuria, proteinuria by activating and entrapping these local in situ formed immune complexes, which then recruit various complements or recruit the cytokines and eventually lead to the damage at the level of the endothelium and leaking out of of RBCs that we manifest at hematuria and proteinuria. And with all these things going on, whether it's complement mediated or podocyte injury, or whether it is at the different levels of activation of B cell or naive T cells, various glucocorticoids, or anti-CD20 agents, or anti-BAFF agents, anti-APRIL agents, calcineurin inhibitors, cyclophosphamide, anti-metabolites, and the proteasome inhibitors, anti-CD38, they're all coming in, and along with the new kids, the C5 basically antagonists, receptor antagonists, which include iptacopan and avacopan as very promising therapies, respectively for various forms of whether it is granulomatous angiitides or you're looking at IgA nephropathy. Case 4 is a 75-year-old male who has low-grade fever, malaise, maxillary sinusitis. He has decreased appetite, 4-kilogram weight loss, high blood pressure, mild pallor, tender left maxillary sinus, crusty nasal septum, ankle edema. Hemoglobin is 13.5 with a normal MCV. Creatinine is 3 milligrams per deciliter. Ultrasound shows normal-sized kidneys, and serologies have been sent. Urine dipstick shows 3 plus blood, 2 plus protein. Sediment reveals 6 to 8 red cell cast, dysmorphic RBCs on phase contrast microscopy. Proteinase 3 is positive, but MPO is negative, and ANAC3C4 anti-GBM are negative. Kidney biopsies planned. Immunosuppression, meanwhile, is immediately commenced with pulse steroids and followed by cyclophosphamide. And this appears to be a classical RPGN a picture with the granulomatosis with polyangiitis, and the biopsy would support that. But in addition to that, even clinically, this DC-VAS classification in vasculitis, where scores over 5 and 6 have very high sensitivity and specificity for ruling in or ruling out GPA, MPA, and eGPA. I would urge you to be familiar with that. For instance, in GPA, if you have nasal involvement, cartilaginous involvement, and C ANCA or PR3 positive, you already get 8 or 9 points right there along with these nodules. And in MPA, on the other hand, a nasal involvement would give you a -3. So it rules out also. But if you have a P ANCA or MPO positive and is ILD or lung fibrosis or post-immune GA and otherwise, then you can certainly be in this category. So this can be differentiated from your eosinophilic granulomatous polyangiitis, where hematuria would be extremely rare. Case 5 is a 46-year-old female who presents to nephrology clinic with generalized edema of 2 weeks duration. She was previously well and asymptomatic. Blood pressure is normal. She has decreased by sounds right lung base, 3 plus petting edema. Creatinine is normal, but albumin is lower at 2.8. Fasting cholesterol is 300. LDL is 160. Dipstick reveals 4 plus protein. Trace blood. Microscopy shows 5 to 10 RBCs, but no cast. But you have oval fat bodies and hyaline cast. The 24-hour urine protein is 6.5 grams. Complements are normal. PLA2R antibodies are raised at over 200, and hepatitis B, surface antigen, and hepatitis C are normal. Other screening tests are negative. It's probably membranous GN based on the nephrotic syndrome, inactive urine sediment, oval fat bodies, normal complements, high PLA2R, and consensus with the patient can be developed to avoid a kidney biopsy if they don't want one, and because it's a very highly specific PLA2R antibody titer, supported by the KDIGO guidelines, and one can then use ACE, ARBs, and rituximab or cyclophosphamide, depending on the progression within 6 months on conservative therapy to begin with. So this is how one would use your PLA2R antibodies. And of course, cancer-specific screening should be done even with primary membranous, if it's PLA2R. Cases have been reported with this as well. So in general, if you have a high PLA2R antibody with proteinuria and creatinine, you can follow the titers and start immunosuppression if they are rising, or if they fall, just watch expectantly on conservative therapy, ACE inhibitors, ARBs, lipid-lowering therapy. But if you have nephrotic syndrome or high titer, then of course we should start immunosuppression pretty early, especially those who fall in the moderately high risk to very high risk categories. And similarly, if you have non-nephrotic proteinuria, you can just follow along. But if the titer starts increasing, you can start immunosuppression. So the kidney biopsy, of course, is the gold standard, and it's had distinct patterns. If it's described as diffuse, majority of the glomeruli, more than 50% involved. If it is focal, less than 50% of the glomeruli involved. We could have diffuse or focal proliferative patterns, or segmental pattern where a sector of the glomerulus is involved. And like microscopy needs to have all the stains, H&E stains, trichrome, silver stains, Congo red, etc. But there are distinct patterns, as we know, in crescentic GN, necrotizing GN, diffuse or focal proliferative varieties, focal segmental sclerosis, diffuse intercapillary glomerulosclerosis in diabetes, mesangial proliferation in IgA or IgM nephropathy, membranous nephropathy, C3 glomerulopathy with the mesangial capillary type changes, or minimal change only detectable as a normal on light microscopy and only proven on a electron microscopy. Immunofluorescence, one should do staining with C3, C4, C4D, C1q, IgG, IgM, IgA 1, 2, 3, 4, particularly IgA 4 in membranous or IgA 1 in secondary membranous. Pauci-immune would be a feature of the vasculitides, granulomatous polyangiitis, and kappa lambda patterns need to be also stained for. Then you can have granular, linear, mesangial, full house patterns that you may be aware of, and electron microscopy is very useful to have if you can afford it. And of course, you can have food process effacement, subepithelial humps as in post-infectious GN, subendothelial, subepithelial, or intramembranous deposits as in membranous, or you can have the amyloid, fibrillary, and immunotactoid deposits that can be seen on electron microscopy. In general, primary glomerulonephritis, there's a change in pattern over the past decade. IgA nephropathy usually be 23.9, 24%, highest in most series now. Membranous is a close second, followed by FSGS. And I think pretty much this is been the pattern, although in my parts of the world, even FSGS seems to be on the top. But minimal change and MPGN and crescentic, all those things follow in that order. This was from Yusuf series in 2020. And in a series of secondary GN, the highest was lupus because of, as a secondary GN, about 41.8% of biopsies, but diabetes was also there at 20%, despite the fact we don't normally biopsy patients that we suspect with diabetic nephropathy. So these are those who are suspected with something else, but turned out to be diabetes too. And ANCA vasculitis followed by TMA and amyloidosis and others as shown. These are some of the patterns you can see in endocapillary proliferative GN, or mesangial proliferative GN, or membranous proliferative lobular type GN. This is the IgG4 in a granular pattern in the primary membranous. And this is, you can see the tough compression with the parietal cell crescent here, very clearly seen with fibrinogen deposits. This is the IgG pattern in pauci-immune GN, not very prominent, but the C3 and IgA in various degrees are prominent. If it's C3 GN, C3 is more prominent. If it's IgA, IgA is more prominent. And similarly, the kappa and lambda light chains may be stained and seen on immunofluorescence. And likewise, the corresponding changes with electron microscopy include loss of epithelial foot processes or various forms of subepithelial humps that you may see in subendothelial humps that you can see in post-infectious GN. Case scenario 6, a 24-year-old male presents with distressing third episode of gross hematuria occurring each time with simultaneous pharyngitis or tonsillitis. Blood pressure is 140/85. Creatinine is normal. Sediment shows high dysmorphic red cells, few red cell counts, 2+ proteinuria, albumin to creatinine ratio 600 milligrams a gram. Serum C3-4 are normal. Kidney biopsy reveals mesangial proliferation. Immunofluorescence reveals 3+ IgA, 2+ C3. Ours when SGLT are commenced, and after 6 months, the proteinuria is still significant. And so based on the testing trial, 0.4 mg per kg per day, prednisone started, and it appears to be IgA nephropathy based on synpharyngitic hematuria as opposed to postpharyngitic, and the mild to moderate proteinuria, normal C3, C4, active sediment, kidney biopsy, or showing mesangial proliferation with IgA and C3 are all confirmatory. And you can use either low-dose steroid as was done, or you can use budesonide for local Peyer's patches related suppression, or based on the 4-hit hypothesis, you can go with, along with that, MMF in Chinese population, or you can use the C5 complement inhibitors or the BAF inhibitors as they're becoming more popular besides the SGLT2 inhibitors. So in general, with IgA nephropathy and staph-associated GN and C3 glomerulopathy, IgA would have normal complements and they will be low in staph, but normalize after appropriately treated infection. But in C3, they'll be persistently low. And you'll have this mesangial proliferation in IgA, membranous proliferative pattern in C3, diffuse endocapillary exudates in staph-associated GN, and of course, you will have mesangial location of the deposit and a hump-shaped deposit in subepithelial location in staph, GN, and mesangial and subendothelial or intramembranous deposit in C3 glomerulopathy. You can have a strong C3 staining in IgA, but strong C3 staining IgA and IgG codominance in staph-associated GN, and C3 staining with IgG staining less dominant in C3 glomerulopathy. So this is important to be aware of. So this is a 5-year-old female born in a consanguineous marriage. She has recurrent foamy urine and proteinuria and nephrotic based on her age and amount in terms of milligrams per body square area meter squared. And she started on steroid, does not respond. She started on tacrolimus and referred for next generation massive parallel DNA sequencing test, which suggests a genetic feature to this, which will less likely respond, but can be referred to specialized centers for clinical trials. So genetic testing in glomerular disease can be very useful for genetic podocytopathies, to avoid a biopsy when there are contraindications, to inform prognosis, and to screen for extrarenal complications. For example, if you have hearing and visual impairment, of course, for Alports, then you would send the patients to the appropriate specialist, and to identify others at risk in the family, and to identify suitable family donors and avoid unnecessary immunosuppression in these glomerulopathies, but also be able to refer them for specific clinical trials. So in general, if you have proteinuric state in adults, clinical evaluation for kidney biopsy, including EM. If you have nephrotic syndrome, diffuse foot process effacement, first-line therapy, and you have resistance, go for genetic testing. You have no nephrotic syndrome, diffuse foot process effacement, go for genetic testing. If you have nephrotic syndrome or no abnormalities and no evidence of secondary causes, go for genetic testing. And of course, if you have no nephrotic syndrome, segmental focal foot process effacement and evidence of secondary causes, then consider secondary causes. Case 8 is of a 60-year-old male with a 2-week history of fever, malaise, reddish-brown urine, coughed up bright red blood. Creatinine was also 5, blood pressure was 160/100. He was hypoxemic, he has red cell CAS, and he has bibasilar infiltrates and hypoxemia. And he's transferred to the ICU where he's given pulse IV steroids, and plasma exchanges are commenced, and cyclophosphamide is commenced along with that. The kidney biopsy reveals cellular crescents with a linear IgM pattern against IgG, and anti-GBM antibodies and MPO are both reported positive. ANA, C-ANCA, C3, C4 normal. So this is an acute presentation of RPGN of anti-GBM disease. And so kidney biopsy is classical with this linear immunofluorescence along the basement membrane. So you need to have urgent pulse steroid, cyclophosphamide, and Plex, as was comments. This last case is of a 70-year-old male who presents with backache, nausea, constipation, excessive urination, blood pressure is normal. He has lost some vertebral heights. ESR is 110, hemoglobin is 10, creatinine is double, calcium is high, albumin is low, urine dipstick is negative for protein or RBCs. However, the serum immunofixation and protein electrophoresis are positive for a monoclonal band in the gamma region, and kappa light chains elevated with kappa lambda ratio of 3:1. Bone marrow biopsy reveals 40% of plasma cells. Kidney biopsy shows proliferative nephropathy with monoclonal eosinophilic immune deposits, and cyborg with cyclophosphamide, bortezomib, and dexamethasone-based immunosuppression is offered to this patient. Normally, you have albumin, alpha-1, alpha-2, beta, and gamma range. But if you have a monoclonal spike in the gamma range, you can confirm it with immunofixation. And here you find that it was predominantly kappa kappa light chains were the predominant component of this monoclonal gammopathy. And the nodular sclerosis is very similar to the diabetic Kimmel-Stein-Wilson nodules is also quite pathognomonic in these cases. And you can see that on the on the electron microscopy, and these kappa light chain deposits are also very prominent. So you need to be familiar with all the guidelines like the KDIGO 2021 and its periodic updates, and know how to look at literature at the point of care, appraisal of literature for RCTs and systematic reviews for areas such as number needed to treat or number needed to harm is extremely important to avoid getting misled. And patient values and preferences, or to act as a patient's best agent, is important, especially when making biopsy or therapeutic decisions in our parts of the world. And one should have a person-centered approach incorporating kidney health education for all. For instance, in this diabetic CKD patient with diabetic nephropathy, from nutrition to smoking cessation, blood pressure control, RAS blockade, GLP-1RA, lipid management, weight control, MRAs, metformin, glycemic targets of less than 8%, or exercise of 150 minutes per week. They're all extremely important for patients who have not gone on dialysis yet. And this is a booklet that I use, that I have authored, Kidney Disease Health Education of Patients and Families. If you just go to www.maroof.com.pk/ebooks, double-click it, you can download a complimentary copy and use it for your patients, especially the English-speaking ones or ones that you can translate for in your local languages. So in general, you can present with asymptomatic proteinuria, microscopic hematuria, nephrotic or nephritic syndromes, rapidly progressive GN, chronic GN, and the take-home points have already been emphasized in terms of going through all this. And I would like to show this pictorial that start off with epidemiology, pretest probability, which is age-specific incidence and prevalence, family history and genetic correlates, look at the clinical presentation, the historical pattern, acute, subacute, or chronic, patient-reported symptoms like gross hematuria, frothy urine, periorbital puffiness, dependent edema, fever, malaise, skin rash, arthralgias. Do a good review of system, physical examination, always measure blood pressures yourself, do a fundoscopy, look at the nasal and oral mucosa, comprehensive skin examination with proper exposure, cardiovascular respiratory system, abdomen and neurological examination, do the urine dipstick yourself, do the urine sediment yourself, order a serum albumin creatinine lipid profile, the serological tests as indicated, hepatitis B, C, ASO, PLA2R, ANA, anti-GBM, MPO as indicated, blood cultures as indicated, complement C3, C4, serum urine protein electrophoresis in the right age group, kidney biopsy where required and normally is recommended, and genetic testing as indicated. And you can have the clinical pathological correlates in terms of whether this is an asymptomatic urinary abnormality, nephrotic nephritic presentation, rapidly progressive GN, or histopathological evaluation with light microscopy, immunofluorescence, and electron microscopy. Then come to a post-test disease probability and final diagnosis, where you can now concentrate on salt restriction, low cholesterol, normal to mild protein restriction, lipid-lowering agents, diuretics, loop diuretics, non-specific blood pressure control, and proteinuria reduction with ACE or ARBs, SGLT2 inhibitors in the right population, MRAs like finerenone, dual RAS endothelial inhibitors like sparsentan, targeted therapeutic regimens like corticosteroids or budesonide, cyclophosphamide, MMF, tacrolimus, or cyclosporin A, biologics like CD20 inhibitors, for example, rituximab or belimumab in the case of lupus here, complement-directed therapies like avacopan or iptacopan, like in ANCA vasculitis, plasmapheresis, and TPP, experimental like BAFF inhibitors in IgA nephropathy, and look at the updated guidelines, regularly have a patient-centered focus. And I end here with an acknowledgement to the entire organizing committee and scientific committee, and especially my dear brother and friend, Professor Brigadier General retired Mamoon Mustafi, for inviting me to do this presentation and giving me the 45 minutes to share my thoughts here, and with a lot of love for myself and from the people of Pakistan, for the people of Bangladesh. Dhanyabad. Assalamu alaikum wa rahmatullahi wa barakatuh.